Questions for the Minister of Health. And I call Paul Bradshaw. Minister.
Principal Deputy Speaker, we're progressing a number of pieces of work to improve transitions for autistic children as they move into adult services, particularly a new learning disability service model, which is currently out for consultation. It's fully applicable for autistic adults with co-occurring diagnosis of learning disability. In relation to transitions, it sets out a framework to support people transitioning into day services, carer support, independent living, healthcare and specialist mental health services. In addition, a transitions protocol has been developed to standardise the planning process across the trusts. Within the draft Children's Emotional Health and Wellbeing Framework, transitions are a key area of focus. I want to ensure young people with a range of neurodevelopmental needs, including autism, are supported and prepared as they navigate the shift from child to adulthood. A public consultation for this framework closed on the 26th of September last. Responses are currently being collated and analysed. I would just say transitions are a long-standing challenge and not just in the Department of Health.
Ms Bradshaw.
Thank you, Minister. I recently met with the Inner South Belfast Parent Support Group of Autism NI, and this was a key issue for them because they've been fighting their whole life for support for their children. Have you any firmer timelines in terms of when they will actually start seeing the programmes implemented on the ground? Thank you.
Minister.
I thank the member. Timelines are something that I'm not particularly keen to commit to, because the member may be aware there have been a number of initiatives, such as the cancer research strategy, which we have said we have put a timeline on, and then we have not delivered on it. So I don't want to continue to raise expectations. But I would say in this case, particularly with adults, as you mentioned adults, I go out, I meet parents of children with learning disabilities, parents of children with autism, ADHD, and one of the common themes, as she will know, is what keeps them up at night is, will they be okay after I'm gone? So it is a matter of urgency.
Mr. Speaker, Minister, parents and carers are really struggling, and one of the main barriers that I am hearing is access to support and access to direct payments. So, Minister, could you provide an update on how this is progressing?
Minister.
I thank the member for the question. Direct payments is something that I wasn't particularly aware of when I took up post 18 months ago, but very quickly was made aware that it is a pretty complicated process. Puts a huge onus on those who are receiving direct payments, because they effectively become employers, and that is maybe the last thing they want to do when they're feeling vulnerable. So I have asked for a review, and again I am actively chasing that up because members will know my view. I don't think the public sector, and I include the Department of Health, is necessarily built for speed on these issues. And yet, if you are looking for help, speed, of course, is of the essence.
Cara Hunter.
Mr. Speaker, Minister, thank you for answering our questions today. It's really important we do all we can to help support young people with autism. Minister, will you agree to establishing a cross-departmental work group to address this cross-cutting issue? As I understand, there's so many different sectors and aspects to this, and to supporting children with autism, from communities, education, etc. Thank you.
Thank you. Mr. Speaker, I'm afraid I'm not going to dream up policy on the hoof, but I certainly accept the logic of what the member is seeking to address, and I hope she knows I am looking for standardised regional services which take in a holistic approach and that we want to end the silos, whether it's over diagnoses, procedures, postcode lotteries. All these things need to be addressed so that we smooth things out, so that people know that if they've got to wait, it's not a longer wait than anybody else. If there are difficulties that need overcome, they're not bigger difficulties because they have autism compared to some other condition.
Mr. Dixon.
Number 2.
Minister.
Thank you. The Department of Health facilitates access for patients to clinical trials, and we do this through the work of the Health and Social Care Research and Development Division in the Public Health Agency. The division oversees participation in UK-wide clinical governance and trial approval processes, and in addition it funds core research infrastructure, which in turn supports access to clinical trials. This includes the Northern Ireland Clinical Research Network, a Cancer Trials Network, a Clinical Trials Unit, and a Clinical Research Facility and research offices in each of the trusts. Approximately 80% of clinical trials taking place in Northern Ireland also have research sites in other UK nations. However, I also want to recognise many clinical trials open only in a small number of sites around the UK and seek to recruit only a limited number of patients who have very specific characteristics. Therefore, not all trials will open in Northern Ireland or indeed will open in any other part of the United Kingdom.
Mr. Dixon.
Thank you very much. Minister, can I ask you how your department is working with the relevant stakeholders like universities and the Trust to make both Northern Ireland an attractive partner for UK-wide and international trials? And why has the department brought about a great deal of confusion with regards to EU rules, which we were told were blocking trials, and then a correspondence from your Minister last week saying, no, that was all wrong, there are no EU blockages to these trials, trials should be able to proceed. In reality, Minister, the blockage is in the Belfast Trust.
Well, to be fair to the Belfast Trust, the Department of Health and our arm's-length bodies rely on these occasions on the advice of a UK-wide body, which is the Medicine Healthcare Products Regulatory Agency, the MHRA. They originally gave an opinion that we had to conform to specific EU regulations, the EU in vitro diagnostic regulatory conditions, and that therefore we couldn't proceed with the trial. It now appears MHRA have reviewed their analysis and we're good to go as long as we have the right governance structures locally through the Belfast Trust. I think that's very unfortunate because it has led to a delay, but I don't think it has led to any patient safety. That particular ball that goes down the throat to look for Barrett's esophagus, I've seen in action up at the Patrick Johnson facility at the Queen's site within Belfast City Hospital. It's magnificent, it is so quick, it is cost effective, and it delivers better outcomes. So it is a matter of regret that we've had this 1 year delay. In terms of how we tap into the rest of the UK, I was at the launch very recently up at the Ulster Hospital of the Northern Ireland Commercial Research Delivery Centre. This is a clinical trial centre. It's brand new, but it's going to link us into a UK network, and I think that's really good news because we've got clinicians who are incredibly passionate about clinical trials. And Northern Ireland is of a size that is almost perfect for clinical trials. When we do them really well. I just happen to think we're missing a bit of a trick by not becoming kind of global leaders, or certainly UK-wide leaders in the field.
David Brooks. Ask on the back of the member's question then, when these patients will have access to those trials, and for clarity, in reiterating what the member has asked, can we be sure that EU regulations are not a barrier or will not be a barrier in future to patients accessing such trials?
Well, I can only be specific about the clinical trials with regard to this ball that goes down on the string for Barrett's esophagus, and the MHRA are now saying absolutely the EU regulations do not apply, so you can go ahead. The reason we can't start it immediately is that we must make sure we've got particularly the right governance arrangements in place within the Belfast Trust. I would like to think they will now proceed at pace, because I think we should all be slightly embarrassed, even though it wasn't our fault, it was the MRHA across the water. But at that, it was a one-year delay that was unnecessary. So let's show the public that we're going to make up lost ground on that. As for the application of other EU regulations for developments in health and social care, I can give the member no assurance. He knows my view. We came out of Europe without thinking through the consequences, and sadly some of the consequences impact on health and social care delivery.
And Alan Chambers.
I was pleased to learn recently that there's been very good progress made on the cancer research strategy, and I think publication is imminent. How important does the Minister believe it was to give the research organisations and individuals locally that further period of time to feed into the draft plan and allow them to work in partnership with the Department?
Thank you, Mr. Speaker. I think I'll respond in a couple of ways to the members. There's really no point having a really solid, what we think is a really solid strategy, if it doesn't have buy-in from stakeholders. And as well as buy-in, I think the other thing is we have to be able to be sure that if we're going to have a strategy, we can follow it up with an implementation plan, and not just an implementation plan, but one that is fully costed, that we're able to deliver. And the member will know I have pointed to the cancer strategy rather than the cancer research strategy, and the mental health strategy as two kind of gold-plated 10-year strategies which we actually cannot afford to implement in full. So it was really important when I got the feedback some months ago that some of the key stakeholders were not really buying into that document as currently written up those months ago, that we step back, re-engage with them, listen to them and react positively. And I think we have done that to the best of our ability, and I believe all the key stakeholders are now relatively satisfied. They're not absolutely delighted. Who would be? You can't expect everybody to be delighted with the strategy, but I believe we've got to a place where we can have confidence that we're doing the right thing by the people we are trying to serve, which are the patients and the service users for whom we're trying to deliver better outcomes.
Steve Egan.
Thank you. Can I ask the Minister for an update on actions being taken to address clinical variations across Northern Ireland?
Well, I thank the member for his question. Professor Mark Taylor, as I think he knows, has become the first kind of elective care lead for me within the history of healthcare here in Northern Ireland. He's looking particularly at the waiting list initiatives, but within that, what we want to do is try and address some of these issues with regard to clinical variation. There are a lot, it's very complex delivering clinical outcomes which are consistent across Northern Ireland. So my ambition is to get to a point where we're delivering standardised regional services, whatever that service has to be. And it's also being led by the Chief Medical Officer, Professor Sir Michael McBride. So I think we've got two really experienced people looking at this area. And I think if we can start making solid improvements, then it will deliver better outcomes, and it will address the idea of postcode lotteries and variance in clinical delivery. and I'm absolutely delighted to know that I've got the right people in the right places looking at this issue.
Dr. Aiken.
Is the Minister confident that his appointment of Professor Mark Taylor as a clinical lead for reducing Northern Ireland's waiting times position will serve as an important opportunity for the focus on why the numbers of procedures delivered on hospital theatres lists can sometimes differ from what are independently recognised baselines such as those by GIRFT?
I absolutely do, and it is something that he is addressing. And it's not a question of, saying to somebody, you've done really well, but to somebody else, you haven't done quite as well, or you're not doing what you should be doing. I spoke to Mark at some length before he went out on the ground in post. I think the fact that he is a clinician and a surgeon is extremely useful in terms of his ability to engage with clinicians and with surgeons across Northern Ireland. I think there's a mutual respect there. And what he's doing is not saying somebody's doing your procedure 10 times a day in another hospital, you're only doing 6, you've got to do 10. It's more a case of Mark saying, this is the variance, let me understand why there is a variance, and let me see how I can help you get up to the best that we can achieve.
Diane Dodds.
Speaker, Minister, last October, I think it was, we held a debate on breast cancer referral times and the 14-day target. And at that stage, the Western Trust were 80-something% within that target, and the Southern Trust 10 and the South Eastern Trust 6. Now it appears that with the creation of a regional list for breast cancer referral, that instead of offering equality, we've offered everything equally bad. What do you say to the lady who contacted me last week, who 11 weeks ago was red flagged for a referral for breast cancer investigation and still has not seen a consultant?
Minister.
Well, I regret the fact that that is such a long wait, but I hope the member will understand the logic of what we did in bringing in a regional service. She's already noted the variation. The Western Trust had the best or shortest waiting times. So what do I say to that person? That I'm very sorry, and I hope she gets the best outcomes when she is seen. What do I say to two people who are potentially neighbours, but the dividing line between the trusts run between their two houses, and who had maybe weeks and weeks and weeks of variation between their ability to get an appointment? That wasn't right either. So to achieve what I wanted to achieve, we had to do two things, and we've achieved the first, which is to level up and unfortunately to drive down the longest waiting lists. In the short term, the shortest waiting lists do nudge up, but then they become equalised. And then we do part two, and I accept we haven't done part two yet, but we are now working on it, and that is to drive down right across Northern Ireland the waiting list towards the 10-day target.
McAllister.
For his answer, and I do agree with the Minister in the issue of ensuring the regional aspects and outworking of each trust needs to be fair right across the board. It absolutely has to be. But would the Minister agree that the true transformation is a key element to that, and that the clinical variations need to come down to the outcomes as well? It's not just about waiting lists, but it's actually about the particular types of services that are offered in each trust. I think about mental health services, for example, that are great in one area and severely.
Right, we'll get the drift, Minister.
I agree with the member, and we are driving it down. And it's kind of an outlier in a way, or it's a demonstration for me, that we can then turn to areas like mental health. Because right across the piece, I want to get away with postcode lotteries. I want consistent, regional, standardised services so nobody feels, because my postcode happens to be X, that I am going to be disadvantaged. That is not in any way consistent with the idea of the founding fathers of the National Health Service.
Mark Durgan.
Speaker, Minister, I understand and indeed support the need for regional standardised services and to do away with those postcode lotteries, as you put it. But what services thus far then are being delivered in that regional manner, and why, I suppose, has breast cancer assessments been used as a pilot? Why have you chosen the one lottery that patients in the Western Trust area actually had a chance of winning, and where performance is better, particularly given the worst health outcomes
Minister.
In that area?
I understand the member is representing the West. I'm representing Strangford as a constituency MLA. I have to park that and put on a role of the Minister of Health for Northern Ireland as a whole. And it was made abundantly clear to me that the variation in waiting lists for breast cancer assessment were not acceptable, and I have done what I think is the right thing. It is a two-party move, as I've explained, and yes, I regret the fact that people in your area are maybe having to wait a bit longer, hopefully in the short term. That's a matter of regret, but I have to take the big picture, and the big picture said this is the right thing to do, and then we roll it out.
Linda Dillon.
Question number 4.
The Northern Ireland Ambulance Service provides non-emergency transport for patients who, due to clinical need, cannot reasonably travel independently. It operates under my department's Transport Strategy for Health and Social Care Services. It's a strategy which promotes safe, equitable and patient-centred transport. Eligibility is determined by clinical need, including mobility, medical condition and any requirement for professional assistance. Once approved, transport is coordinated by NIAS in partnership with the Health and Social Care Trusts. NIAS does not restrict transport by trust boundaries. Patients are routinely transported across regions to ensure continuity of care and timely access to treatment. NIAS also operates a voluntary car scheme which supports mobile patients who cannot use public transport. Cancer Focus NI additionally provides a free volunteer driving service for eligible patients, accessible via referral from a health professional. Other charities may also offer similar support, though availability does vary.
Mrs. Dillon.
Thank you, and I thank the Minister for his answers so far. Minister, as you're well aware, Middlesbrough is a vast rural constituency, and for that reason it is absolutely vital that all of our residents can access the care that they need. So I am dealing with a number of patients who are having to go to Altnagelvin, for example, for radiotherapy. That's treatment every day of the week for 6 weeks, and are unable to get transport right now. If we want to seriously look at delivering health better and transforming health, we need to ensure that the public have faith that if I don't have something in the hospital beside me, that I will be able to access it where it is. So can you give that assurance today that as part of any transformation, we will make sure that every single person right across the north has access to the services
Minister.
that they need?
I thank the member. I should also have added in my opening remarks that we also have a Cancer Support Services Directory, and for those on low income there's a hospital travel cost scheme which may provide financial assistance. On the broader point, the member knows that I consulted on a strategy which was creating a hospital network for better outcomes, because I believe Many people, and probably including myself until relatively recently, wanted every procedure to be delivered at my nearest hospital, whether it was an acute or not. And that is not possible, and neither is it particularly desirable, given the fact we have the potential to move to create hospitals who will be specialists in particular procedures. So again, if you need a procedure and your local facility does it once a week, 30 miles away they do it 10 times a day, 5 days a week, I think I know where you're going to go. But the question is, can you get there and back? So transport becomes particularly important. It's absolutely essential for a relatively small percentage of the population. I think the larger percentage can get there and back by one way or another. But for those who can't, it becomes critical. And so we're looking at all these schemes. The member may also be aware there are ongoing discussions between the Department of Health, the Department of Infrastructure and the Department of Agriculture, Environment and Rural Affairs. And we kind of escalated it a couple of months ago to an interministerial meeting because we feel there wasn't enough impetus. And the focus is going to be on getting people to and from health and social care settings. So it's very much on the radar.
Justin McNulty.
Has the Minister considered working with the Department for Infrastructure and with those within community and rural transport organisations to support this work, rural transport organisations which provide a life-saving transport link for the health service?
As referenced in my previous answer, the Department of Infrastructure and the Department of Health, and indeed DERA, the Department of Agriculture and Rural Affairs, are engaged, and officials have been tasked with looking at how we can help getting people who don't have their own transport to and from health and social care settings. And that involves community organisations like Community Transport. How can we work with them to deliver better outcomes for patients and service unions? So it is happening.
Alan Robinson.
The Minister for his responses today. Just on the back of Ms Dillon's previous question regarding cancer treatment, can he update the House further what action he has taken to tackle unacceptable breast cancer waiting times?
I'm not sure how that relates to transportation. But we are working on, we are very conscious that cancer waiting times are getting longer and that it's not good and that it delivers very bad outcomes. The longer you have to wait, the less likely you are to get an optimum outcome for patients, but it is not relevant. I mean, it's a very important issue, but I'll write to the member because I wasn't expecting that on a question on transport.
Danny Donnelly.
Mr. Speaker, we will all be aware that having a cancer diagnosis is an incredibly stressful time in someone's lives, and attending for treatment is incredibly important. Can I ask the Minister how many cancer patients either missed or had delayed treatment appointments due to transport issues in the last year?
I don't think I have that statistic to hand. I'm not sure even if we trap that statistic, but I'll certainly look out for it for him if we have it.
Butler.
Number 5, Mr. Speaker.
Minister.
The Northern Ireland Fire and Rescue Service Learning and Development College, or LDC, in Cookstown represents a transformative investment in firefighter training, in public safety and in regional development. It is world-class, and Mr. Speaker, I will repeat that because we don't have that many facilities that meet that criterion. It is world-class. It's been operational for 11 months. Several benefits have already materialised, with further gains expected. Its state-of-the-art facilities provide trainees with multiple opportunities to experience realistic and repeatable training simulations within a controlled environment under expert supervision That leads to personnel being better prepared than they were previously, and in turn that enhances the safety of both the public and of firefighters.
Mr. Butler.
Thank you, Mr. Speaker. And as the Minister has rightly pointed out, and I agree with him, it is a world-class facility. And in that vein, Minister, is there any opportunities for other services, either fire service or other, to use the facility? And if there is such a facility in the future or opportunity in the future, would there be opportunities then to recover costs in terms of running the facility?
I thank the member. Yes, absolutely. Well, the first thing I should say, the college being there has led to a reduction in costs in several training topics for the Northern Ireland Fire and Rescue Service itself. That includes breathing apparatus instructor training, road traffic collision instructor training, and hazardous material officer training. They also have the water facility, the flood facility, which is absolutely spectacular. The college is primarily, of course, for the use of the fire and rescue service here, but other emergency services, including the ambulance service here and the police service of Northern Ireland, are already making use of the site. The fire service operates a cost recovery model for third-party usage. At present, this remains under development, so the full potential is not yet fully known. But the Fire and Rescue Service is keen to optimise this to support the effective and efficient operation of the college. I know fire services in the Republic have been to see it, and indeed there's been interest from across Great Britain and I believe further afield.
Honourable Murray.
Number 8, please.
Mr.
All special education needs schools across Northern Ireland have community children's nurses available to manage the identifiable healthcare needs of their pupils. For historical reasons, of the 40 SEND schools in Northern Ireland, only 8 have on-site CCNs in place. These are split across the Belfast and the South Eastern Trusts. In financial year 23-24, the delivery model in Knockhaven School changed to an in-reach model, with CCNs providing assessment and care planning for children with complex healthcare needs. The nurses provided knowledge and skills-based training to key staff within the school, and they were available for queries and guidance as necessary. After engagement and discussion with the Department and the South Eastern Trust, the presence of an on-site nurse in Knockhaven was stepped up again in mid-2025. Currently, a CCN is on-site 2 mornings per week, in addition to the presence of allied health professional colleagues. Following the publication of the Public Health Review of the healthcare needs of children attending SEND schools last month, officials have commenced work alongside colleagues from education to ensure all children in SEND schools have access to necessary health care.
Mr. McMurray.
And just thank you very much, Minister and Mr. Speaker. When will the full review of nursing provision in special schools now be complete, and provide the certainty that is needed? And thank you for the reference to Knockhaven.
I thank the member. So we've looked at the provision of CCNs, the nurses, but it's imperative we ensure all children have safe access to education, supported by the necessary therapeutic support. So the Public Health Agency is leading a comprehensive analysis to identify what the assessed therapeutic needs are for children and young people who attend special school. We need to know the development of an effective model of therapy provision is being planned, and that we have the associated workforce in development and planning. This will include a comprehensive scoping exercise to capture the assessed needs of children and young people in respect of occupational therapy, physiotherapy and speech and language therapy. And to answer the member's question, I expect to receive the completed review with recommendations by March of 2026, with the usual proviso that sometimes our deadlines are not met.
Jonathan Buckley.
9.
Minister.
The Department is currently leading on an e-pharmacy programme. A central component of this programme is the Electronic Transfer of Prescriptions project, which will introduce a fully electronic system to replace the current paper-based prescription process. The system will enable the secure transmission of prescriptions from prescribers to community pharmacies and onward to the Business Services Organisation, the BSO, for processing and for payment. The Department has included this project within its 10-year capital investment plan, with an indicative start date of 2027 at the earliest. Works currently underway to develop the outlined business case. This will set out the strategic, the economic and the financial justification for the project. I remain hopeful, subject to securing the required funding, the project can commence in 2027 and be completed by 2032.
Brief supplementary, Mr. Buckley.
Thank you, Speaker. Thank you, Minister. Could the Minister perhaps outline in his opinion what the potential benefits would be for patients in introducing this system, and also how can we safeguard against error in terms of wrong medication?
Brief response, Minister.
Well, on the latter point, I believe that the GPs and indeed community pharmacists are very aware to checking in case of unintended error, so I don't expect there will be any particular lack of focus there, but using an electronic system does allow you to build in objective tests rather than relying on the subjective eyesight and thought processes of individuals. In terms of its benefits for patients, I'm very focused on the benefit it's going to have for GPs, because every GP I talk to, when we bring up the idea of paper-based prescriptions, they say that is so time-consuming. It would be transformational to have an electronic system. And what I don't understand is I take 5 tablets a day on a repeat prescription. And when I need a repeat prescription, I go on the internet and I fire off an email to my GP pharmacy, and they come back and say, yeah, we've got that all right. But then they write out or they type out, print out a script, and the local pharmacy has to walk up the hill, collect the script, and walk back down to the pharmacy. If it can get from me to the GP, why can't it get from the GP to the community pharmacy? And why is it going to take so long? But it is, apparently.
Moving to topicals, Colin McGrath.
Thank you very much, Mr. Speaker. We have just seen the completion of Breast Cancer Awareness Month, and I wanted to ask the Minister if he agrees with me that it is absolutely abhorrent that we have some of the worst results in meeting detection and treatment targets anywhere in these islands.
I do agree, and I can only assure him it's an area of focus for me, and introducing that regionalised service in terms of bookings for breast assessment was not the beginning and the end of what I intend to do in that area.
Thank you very much, Mr. Speaker. Minister, your party has held the health portfolio for most of the last 10 years, except for those times when inexcusably this place was down. But in the last 10 years, we have gone from 84% being seen within the 14 days down to 6%. Will you develop a specific plan to address this that is more, as members have detailed today, than what you've been offering us of just regionalising the service and making everybody deal with long waiting lists?
Well, on the substantive point, yes, is the short answer. But in terms of the context which the member tried to place it in, I think it's deeply unfair, because the Assembly was down twice, as he knows, during that time. And the only other person in recent years from this party to hold the position of Minister of Health was Robin Swan, who got hit immediately with a global pandemic. which became nearly his entire focus. He did manage, for example, to appoint a mental health champion and get out a mental health strategy. So he did do things, but under the most constrained circumstances any health minister has ever faced since devolution in 1998. So I don't think the context is fair, but in terms of the intent of doing better with cancer services, I'm with you.
Sheila McAleen.
Auditor General that Northern Ireland Health Trust spent in the region of £22 million on 12,000 restricted procedures during the 23-24 financial year. What's the Minister doing to ensure that such procedures are being carried out in line with government policy and that there will be proper departmental oversight?
I thank the member for her question. I was not aware that this was happening until the result came out from that report. It was something that I found actually quite shocking. But the range of activity and the scale of health and social care is such that it is challenging to stay across every development. I did not welcome what I heard because we are in very constrained financial times. And the question then becomes, and I don't have the answer to this yet, are people actioning and signing off on this because they think it's in the best interests of patients and service users? Or is it because people aren't properly focused on the fact that we have this unprecedented and frankly unmanageable pressure on our budget? And I would like to think it's the former, but even at that, we have to review it and make sure that every penny we spend is spent properly, because every pound that is misspent in health is a pound that isn't spent in education, in housing, in all the areas that are in charge of the social determinants of ill health. So we have to spend every penny wisely, not just for ourselves, but for everybody else.
Ms. McAleen.
Thank you, Mr. Speaker. And further to that, and I suppose it's really about spending money wisely, can I ask the Minister what steps he's going to take to ensure that his department's investment of £40 million per year in tuition fees actually benefits health provision in Northern Ireland?
Well, I would be pretty confident that it does, because the workforce challenges remain, although we have invested very heavily and increased the overall workforce who are delivering health and social care. There are still major gaps. Before coming to this chamber, I was slightly delayed because I was listening to somebody in the long gallery who has MS. And it was very awkward to get up and walk out on somebody giving a personal testament. But his point was, we don't have enough workforce in neurology, in neurological services. We don't have enough psychological, we don't have trained nurses, we don't have enough consultants. And that is a common call you would find right across health and social care delivery. So, to my mind, the question is valid. The £40 million, is it being spent to best effect? Absolutely. I think we are pretty much there. But could we use 40, 50, 60 million pounds? Yes, we could.
Jonathan Buckley.
Thank you, Speaker. I know the Minister is very aware of the huge pressures facing dental services today. Can I ask, has he received any concerns from dental practitioners regarding potential abuses of dental provision and wider social services available to asylum seekers in Northern Ireland?
Off the top of my head, no, I'm not.
Minister, dental practitioners and social workers have been in contact with me raising concerns that a number of asylum seeker patients who, in their professional opinion, are most certainly adults, are presenting themselves as children when accessing dental treatment in Northern Ireland. They feel unable to voice their concerns for fear of being branded far-right or racist. So can I ask the Minister, does he acknowledge that if this is happening, this is of huge concern? It presents wider child safeguarding issues for wider use of social services. And will the Minister commit to looking into this issue, which warrants serious investigation, and commit to come back to the House?
Well, again, off the top of my head, I would suggest if the member is holding that information, he should not hold it and he should pass it immediately to the Police Service of Northern Ireland and indeed potentially the Safeguarding Board of Northern Ireland.
All through.
Thank you, Mr. Speaker. Regarding the removal of the Public Health Bill from the legislative programme, the Minister is quoted in the press as saying, "I also fully recognise there were a number of genuine concerns raised, not least questions about how individual human rights would be affected by the introduction of any legislation." Can the Minister outline to this House those concerns and what aspects of individual human rights he talks about?
Well, it was a more broad acknowledgement that there was a concern about human rights and about the government being in a position where they could potentially overreach into people's personal freedoms and decision making. But let me make a broader point, if I may, to the member. It was early in my tenure that I was asked to sign off on the consultation. Perhaps had I been in post longer, I might have come to the view that it was too soon after the COVID-19 pandemic to go to public consultation, because certainly that is the clear impression I get from the 8,000 plus responses to the consultation and indeed the reaction at the time. And the other thing is, a former leader of his party used to say that politicians or ministers don't go out to consultation until they've decided what they're going to do. And the consultation is only to see if they're banana skins they haven't spotted. I don't take that approach. And that's why, for example, I put in mandatory vaccinations as an option. I didn't support it, but who am I to tell the population of Northern Ireland, you can't even have an opinion on that? So that's the reason I put it in, but I made clear, personally, I wouldn't be supporting it. But overall, the 1967 Act has some draconian measures in it, but people aren't aware of that. And just it was in that context of so soon after COVID that I realised we are making people fear for their civil and religious and human rights liberties.
Mr. Speaker, and I thank the Health Minister for that very honest answer, and I thank him for it. And I also applaud the fact that he has removed the Public Health Bill from the legislative programme. But can I ask the Minister then, out of that question, if it was wrong to do it now, so soon after the atrocious decisions taken in the Department of Health around the COVID pandemic, why he would think it would be right in 10 years or 20 years' time?
Because I don't accept the member's assessment that there were atrocious, quote-unquote, decisions made in the Department of Health at the time, and the member and I clearly would disagree absolutely fundamentally, and that's fine. It's absolutely fine that we should disagree fundamentally. But what I would say to the member is the 67 Act, I think it's the 67 Act, only deals with infectious diseases. We're in the 21st century. We need in all hazards to take in biological, chemical, nuclear, all those horrible threats that have been developed down the years. So although I'm saying we're not going to bring it forward this mandate, what I've said to officials is we have to go and re-engage with people and try and make them understand two things. First of all, the implications of what we have, which I say have some fairly draconian measures in 67 about how you can detain people, which you obviously would be 100% against, and I might agree with you on that particular one, about a mandatory detention of people without going to the courts to get permission. And secondly, to say, let's think about all the other issues that have arisen since then that we don't have covered. So I would like to think in the next mandate we will do a new public health bill which will be more to your satisfaction. Not entirely so, but more so.
Can I call you and thank the Minister for his answers? Minister, can I ask you for an update in relation to ambulance waiting times, particularly in relation to Alton and Galvin, where there's some very worrying messages coming out in the September review?
Well, I thank the member. I'm going to write to him on this, if he doesn't mind, because while ambulance waiting times have been bad down the years, I'm getting a hint that there's some really solid positive news. And it includes Alton and Galvin, because it was Northern Ireland wide. So I've listened to the follow-up, but there is a focus being put on it, and the focus is beginning to yield results.
I thank the Minister and I look forward to that information. I suppose, Minister, the situation in Alton and Galvin has significantly worsened since the removal of emergency general surgery, and you will be familiar with the phrase of double ED weights for patients from South West Acute. And those double ED weights continue. The ambulance service themselves have outlined very worrying, prolonged delays. So can you indicate that what engagement you're having with that trust in relation to removing that double ED weight, which is discriminating against patients coming from Fermanagh?
Well, let me again go and check exactly where we are with the double ID weights. So it was the RQIA assessment of the impact of removing emergency general surgery up to Alton and Galvin, which I suppose exposed to the public the idea of you have a waiting assessment in the ED in the South West Acute, but then you have to do it again when you get up to Alton and Galvin. I think they were already, as it were, on it. They hadn't cracked it, but they were aware that this was an issue that needed to be addressed. You didn't have to do the double ED. And also, of course, Encompass allows for, instead of having to put a big file, physical file, in an ambulance with a patient, you can say, this patient will be with you in whatever time, and the incoming team can look at Encompass and look at the diagnosis and all the rest. So if the double ED is still happening, I would be concerned about it, and you're nodding to say it is. I'd certainly take that away, because I was of the impression we might well have seen it off by now.
Thank the Speaker. Could I ask the Minister, it has come to my attention that there are a number of deaf community within my constituency who have not been able to access a social worker who can communicate with them with any form of sign language. So could the Minister confirm how many social workers are trained across the Northern Ireland Trust, and in particular in the Northern Trust area?
Oh, well, if you're looking for specific numbers, I'll have to write to the member, but there is certainly a shortage in terms of social workers, social care workers. So I'm afraid what she's telling me does not come as a huge surprise, but in terms of the fine detail, I would have to get back to her in writing.